We're going to call it critical mass. We're going to get going. So, laterals. So we've all seen the slide, and a bunch of different ways to approach the spine. And this talk is primarily going to be focused on that XLIF category there, but there is the oblique lateral approach, which is kind of mirrors what this talk is about. So people ask us if we do that or not. We typically are going trans-psoas, but there are times for sure where we definitely have a more anterior starting point, but we typically end up more direct lateral than we do working the entire time in an oblique plane. And we can talk to the benefits of that or whatnot, but that's an easy modification to make in your practice if you're someone that chooses to do that ATP or anterior to the psoas approach. So this is I think a surgery where the technique does matter. There's anatomic considerations that you have to take into play. Then there's, unlike other procedures in general, there's more logistical concerns in the surgery. In other words, the room setup, what you're doing with the table, where the break is, even where the C-arm is, and all that kind of stuff is important. The neuromonitoring is oftentimes a combo because it's driven by what you're seeing, but also by what they're doing passively. It used to be that we used to use this we would do all our own placement of the needles and monitor all our own cases. That was at the very beginning of XLIF. We did everything on our own, and then we've transitioned to the way it's currently done, primarily because there's some advanced techniques that they can use that's helpful, like doing saphenous nerve monitoring and kind of doing continuous monitoring of motors and stuff like that, which is. Well, if you're doing the procedure and you're having to pay attention to all that is a little bit much. For interaction with anesthesia, of course, and then for many, it's still a new approach, which it's definitely gotten a lot more attention, I think, in recent years in fellowship programs. So I don't think it's as new as it has been historically, but it still is. And then the fusion bed prep, I think, is critical, unlike some other approaches. So, and it's always critical. It's just that there are other elements at play here, primarily probably time to a certain extent. Okay. So, there are some obstacles to adoption. The room setup is one of those things that can be a bit daunting for people that aren't used to going lateral. Monitoring, but I think since we're using other people to do that, is not as much of an issue. It's an unfamiliar approach in general. You're going into the abdomen, which freaks most people out, and then you're having to navigate the lumbar plexus, which has its nuances. And then if you're doing deformity surgery, a lot of times it's not a single approach. And so that can be an obstacle. And then there's cost of implants and then radiation. So although the radiation piece is getting a lot better now with NAV, there are NAV platforms that are getting to be a lot better with lateral, but it's still a potential obstacle. When it comes to when to use this technique, I think indications are really important. What are you trying to accomplish? Is it just being MIS or trying to do an indirect decompression? What are the fusion indications in that patient? Understanding the segmental global alignment, and are you doing a deformity correction? So main thing is, like, if the fusion is indicated, it's almost always outside of 5-1 going to be something that you should have on your table as, hey, is this a better one for lateral? Why not go, when not to go lateral? So if they've had previous retroperitoneal exposure, just have it on your radar. I don't think it's an absolute contraindication. We do a lot of it, but it's kind of there. It's like doing a revision ACDF. It's just you're a little bit more nervous, right? It's doable totally. You just have to be aware. And then neuroanatomy, there are times where you're evaluating the MRI pre-op, you're just like, it's just too much nerve tissue. Like, it's just not worth my anxiety today. There's vascular anatomic issues that can be of concern. And then obviously the fusion is not indicated. And then if you're not comfortable doing the procedure, doing a 4-5 with a high crest with, a bunch of nerves in the way, it's probably not the day try to adopt this. So, other thing is expectations. I think both from the surgeon and patient side of things, like from the surgeon side of things, you have to make sure you're comfortable with it. From the patient side of things is just don't do harm. And so it's a great technique to get to do a lot of things, but at the end of the day, you have to be comfortable. And there is a learning curve, as there is with anything in your practice. But once you adopt it, it's a game changer. And then, understand the role you play as a surgeon again in minimizing the side effects or complications. And we believe most of the times that the lateral approach really is a way to avoid a lot of bad things. So, diving in a little bit more, Moro, this is this is Gilad Regev's study, looking at what happens to the anatomy with rotation, and they mainly looked at adult deformity patients, but kind of milder scoliotic patients to see what happens to the safe zone. And the safe zone is what they call the area between the neurologic structures posteriorly and the vascular structures anteriorly. And basically all they said is that the safe zone gets a little bit narrower the lower you go down the spine. And then there are some rotational considerations that make as well as the spine goes into its rotation in the scoliosis. So just be aware of those patients where the vascular and neurologic anatomy can be affected by rotation. Typically, if you're going on the concavity, the spine is rotating away from you. So you're going more anterior with your approach. But ironically, the safe zone is actually a little bit bigger because on the convexity, things are rotating towards more posterior. So I comment on transitional anatomy. We traditionally call this the Mickey Mouse ears that you see on the right in transitional anatomy. Transitional anatomy, simply in this sense, what we're looking at mainly is psoas anatomy and watching the psoas have this sort of like, it looks like it's being pulled anterior. When you see that, just be aware because the typical plane for you to get in can sometimes be a lot more narrow relative to the neurologic structures that are there. So, Mickey Mouse. Again, just basics on vascular anatomy. These are the things that your eyes will immediately go to the neurologic structures on an MRI. Will immediately go to, usually all the typical things. You have to train your eyes to think about lateral. So every time you look at an MRI, you should be like, can I get a lateral implanted there? And like, if you just start thinking about in clinic when you're looking at every MRI, you should always be like, huh, can I navigate this where the vessel's at, where the potential conflict? So just be aware of that. Aorta, vena cava, iliac veins and arteries, and then just be aware of it. Okay. So here's just an example of a 4-5 that seemingly has a navigatable psoas. But if you look at the contralateral side, there is potential for vascular issues given the location of those structures. And you guys see us going across the contralateral side of the cod. That's when this would be an issue. So maybe not in a 20-year-old with pliable vessels, but in a 70-year-old, which we're typically operating on, they may not have the same compliance. So these patients typically go to the side of danger rather than avoiding it. So that therefore, if there's an injury, you're looking right at it. Again, this is that Regev article looking at vascular structures, and you can see that the rotation, how that affects the neural anatomy, how it's rotating. So then there's directional monitoring. You see it's using this when we go in and dock. So you put your dilator in and you're kind of looking around you. So you'll frequently hear me say that there's like 3 different eyes that you have in the operating room. These are eyes that you're actually looking at the patient with. But then you have your radiology, so that's your C-arm or whatever you're using. And then the third is actually this. This is like your neurologic eyes. And so when you're monitoring these, you kind of want to know where you are. The thing about directional EMG is it sends out a pulse in a particular field. So it's like sending it straight out versus there's some probes you put in and it's sending out a widespread No, so it's going to tell you if there's something around you, but it won't tell you if it's in front of you or behind you, to left you or right of you. Okay, so that's where directional EMG we think is better, because it does allow you to it allows you to pulse that um, electrical signal into the direction that you're trying to understand. And so that's going to be important when it comes to figuring out where you are in space. So, for instance, if you have this, if you're right in the axilla of the nerve root, you should have something that's pretty high in front of you. You should have something that's pretty high behind you. And if you have something that's high in front and high behind, time to take that thing out. That's not where you want to be. Okay, you put a dilator in the retract, that's going to be a problem. In this case, you're posterior to the nerves, which can happen on occasion. It's not common, but it can. But in this case, you'd have high signal in front of you, low signal behind you, which is the opposite of what you want, right? And then obviously, if you're in the right position here, you'll have high in front of you, low behind you. And then depending on how close you are to the nerve, as you swing that superior and inferior, and you're letting them know where you are with your nerve pulse, with your signal pulses, they'll tell you, usually those numbers should get a little bit lower as you go down. So what if the thresholds are low? You want to always check the patient positioning, make sure you are where you think you are. So bringing X-ray can be a good thing. And then obviously use the directional capabilities, but you may need to pull up and out and redilate. It's not a big deal, but you may need a bigger cuff of psoas to take with you, because you may be too far posterior. At 4.5, a lot of times we dock more anterior first, like at the 50-yard line or something, 70-yard line, more anterior. And then once we get down onto the disc space there, sweep everything back. All right, so that gives you a bit of a buffer back there. And sometimes you do that before you're getting working. Sometimes you do it with simply repositioning in there manually. And then obviously always want to watch the free run, and then now we use a lot of saphenous nerve to monitor the quad. So that's been some good studies looking at the saphenous nerve as being one of the keys to understanding your neural anatomy. So when it comes to retractor manipulation, we'll do this sometimes, usually pretty quickly, and it may be without you noticing that much that it's it's important. So you can see here we docked a little bit more anterior, and open it up a little bit, and then basically you're just, that was a video. All right, that's awesome. Let's see if it'll play. All right, sorry, it's baked into here. Yeah, right. So you basically move the retractor more posteriorly with your eyeballs, right? So you're looking at it and you leave your wire in there. And your wire is that set of eyes. Remember I told you, like, it gives you reference to where you're at. So if you dock at the 50-yard line and you're looking down inside and you move the retractor posteriorly, you know where the retractor is relative to your wire. So you're just using your wire as your primary way of understanding where you are. And I think for orthopods, it's pretty easy. We use K wires a bunch, so it kind of makes sense to us. I think for the neurosurgeons, when we train them, that's a little bit of a leap, because they're just not using K wires to do reductions. It's like mainstay in trauma, and peds is like we're using K wires all the time. So then, obviously you get a better view of the disc space once you do that. So that's kind of active repositioning. So genitofemoral nerve, it deserves just a mention here. So in general, for the genitofemoral nerve, it's an important nerve because of what it innervates, right? So labia and penis, basically, right? And so zone 3 is typically safe. All right, so genitofemoral nerve actually becomes a problem the more anterior you go, especially across these different segments. So you just want to know where you're at. So like at L1 and L1, 2, and 2, 3, you're going to be pretty safe in the zone 3 corridor. But as you go further distal, the genitofemoral nerve lies more anterior. So it's just not a nerve that you're going to usually see. It's just one you have to kind of be a little bit more aware of. You can't monitor it, so it's a little bit challenging. And it's usually not sitting flat up against um, the disk space. It's usually inside the psoas or sitting on top of it as you come more distal with it, because it comes out of it and pierces through the psoas and lays on top of it. So if you're seeing stuff when you're going, if you're like shallow docking or you're taking a look and you see a nerve, it's, especially in the low lumbar spine, that's probably what you're looking at. So the other thing about 4-5 is positioning is really important. We don't overbreak the table. We like to do a single pass through the psoas. Try not to wand. Again, use your monitoring, minimize your retractor time. Use your angled instruments when you need to not put excess tension on the system. And then here's kind of what that looks like with angled instruments. I'll kind of show you on a couple of slides here. Where you're docking, you have a high crest, and so you're coming at an angle, and you're not orthogonal. So this gets a little tricky because you're going to use your X-ray eyes to make sure that you're in the right spot. Also, on how even the retractor opens, et cetera, it's going to be more challenging. But the bottom line is, if you get into a good spot, especially on look at your AP after you know where you're at anterior posterior, and then just use your angled instruments to do what you need to do. You can see angled cobs. Angled disc prep, angled box cutters if you need them, angled trials, and then angled implants to get the actual implant in place. So it's the same technique. It's just learning to work without being able to see it perfectly down the tube. Just a few notes on fluoro. Make sure you have a very, very good fluoro image in the AP and lateral planes. Like there's different ways of doing this. You'll see how I do it. You'll see how Bruffy and Bagris and Andy Slacks do it. But Malone's, Stevens, but like just there are little techniques and nuances. Pay attention to everyone. You'll kind of develop your own way of doing it. But the bottom line is you want to see your pedicles. You want to see the spinous process bisecting if you can, as long as they still have the spinous process. Just make sure that it's symmetrical. That's really important that you don't get caught, because if this is off, you're off in the anterior posterior plane. Right. So if you go to a lateral, you think you're good, you're actually not. So the spine's rotated. On the lateral, I personally prefer the caudal level to be perfect. If you have a scoliotic, level, if it's just even if it's segmentally scoliotic at one level, one end plate will be clean, the other one won't be. I like to have one clean end plate because it tells me I'm perfect, at least in that one end plate. So I get a super clean view of one of them. I don't care about the other one. And I always go with the caudal one because I figure I'm building a building, so I want the foundation to be perfect. That's my usual. So just make sure it looks like the top right, not the bottom. So the bottom shows you, when in a scoliotic angle head, you have a smooth end plate on one, and then you can see that the cephalad body is not quite perfect. On these rotational ones, just be aware a lot of times that you'll be coming back to your approach corridor, right, which is actually right through the abdomen. That's not ideal. So you're coming in this way though, right? So you're trying to work through the retroperitoneal plane to get to the vertebral body. This looks like it's impossible to do. Trust me, it's very possible. It's just a little bit trickier navigating the anatomy and your retractors and stuff like that, but it's totally doable. Which side to approach? We typically approach the concavity. The main reason for this is that you can basically release the collapse side. It's easy to do 3 or 4 levels, usually through just a single incision, and you can't access things. So you can't access 4 or 5 convexity, right? So that's convexity of the main curve. You're in the fractional curve down here, but there's no way to get to that from lateral. So, and again, minimize incisions and it clears the crust. Few words on subsidence. Things can look good in the OR and then not so good afterwards. That was back in the day when we were using smaller, narrower implants. Now we, in general, only use 22 millimeter wide implants. Most companies that sell these are using these larger implants for sure. simple equations, right? You want to decrease your force, you have to change something. So you decrease your pressure, you want to change something, which is usually increasing your area here, and obviously minimizing the force that you place the implant with. So, the idea here is if you look at the apophysis, it's not all created equal. The more anterior your implant is, the weaker the apophysis is. The strongest bone is, and this is actually really good for fractures as well, is like that area right by the pedicle in the back of the end plate, right? So the closer you are to the back, that's the hardest, strongest bone. So the more anterior you go, the weaker it is. Just be aware of that. Typically, we're shooting for the implants to be right pretty close to the middle of this thing. Be also aware of the morphology of your end plate, though. So is it a heart shape? Is it truly an oval? Is it more boxy? Everyone's are a little bit different. If you look at that, that'll also teach you a little bit, because on the AP, it may look like a 55 length is perfect. But if in the back of the head, you know it's a heart shape, then you may not want to be at 55. You may want to be at 50 or 45, just depending on where you're ending up putting the implant. Because when you look on the inside, it'll look normal every time. Yeah, getting, I think one of the reasons why this works really well is we're using the apophysis as strength and stability, which is why I think non-unions are also really, really uncommon. You're getting great contact. And then again, you do want it long enough to go from apophysis to apophysis. You don't really want this to sit inside. Schematics of the different ones, although like these are changing too now. Some of the TLIF implants that we have are massive. If we looked at the wide versus the standards versus the XLs, and when we came out with them, the XL wides, they really decreased their subsidence rates pretty dramatically. And we even went to a time where we're using 26 millimeter wides, which they're definitely still available. If you have a really big guy, just be aware. If you need the bigger ones, just I usually have to ask for them. So, but they still keep some here. And I don't even know if they made Mundis in 26. I think we may have just stuck with 22. So these are the peak ones back in the day. But you can definitely see the resistance that they have, the subsidence. So end plate coverage is important. Don't overstuff. That's the other thing. Don't try to really cram something in there. Understand the patient substrate, if they're osteoporotic or not. And then be super careful with your end plate prep and always go wide. So when it comes to the actual procedure, and by that we're saying we're docked now. Now we're going to do our end plate prep, or we're going to do our disc prep. My little sermon is be really consistent. Try to be efficient, and that doesn't mean fast. It just means efficient. Don't repeat steps if you can avoid it. It should be simple and elegant. For those of you that have done TFNs and you took pride in how quickly you did them, if you look at your back table, it was all lined up for you, right? It's like, all right, I'm doing this, I'm doing this, I'm doing this, I'm doing this. And it's kind of like the systematic way to it. That's how, to me, lateral should be. Don't waste steps, and then just be reproducible. That helps your tech, your anesthesiologist, helps the workflow, helps your fellows, helps trainees, your PAs, whoever's with you, fluoroscopists, etc. So these 8 steps to efficient disc prep. The reason I categorize them this way, there's always leeway in how you move things around, but for my brain, it just helped me be able to go through 1 through 10, or in this case 1 through 8, and then I'm done. And then my back table is super simple, so that it has all 8 steps there. We're just going to go and get it taken care of. So first part is when you're making sure that when you're docked that you're a bit posterior. So just before you're getting going, you just want to make sure that you have the right window that you can actually do the procedure that you need to do. You can check it with a box cutter or a trial to make sure that the window's big enough. I typically, we just typically turn it to tell how big the window is typically. So first step is at making your annulotomy. What's different in the lateral than perhaps anterior is that the end plates do come together a little bit more on the lateral parts of the vertebral body versus anteriorly, they're usually gapped open a bit. So we still have to take a window out of disc, but it's not uncommon with these disc being so collapsed. The most you get in there is just even cutting your knife through the disc space, right? So, but if you can take out a window, take out a window. And then I actually go as deep as you see here. Like if I'm docked posteriorly and I'm in a good place, I'll take that knife halfway through. The reason is I'm trying to open that thing up as much as I can. And again, that's more about efficiency. So I'll make my box with just the knife, then I'll send the knife deep on the inside, and then I'll just like cut it around circumferential. Next, I go straight to the cob. I don't use a pituitary because, again, it's sort of a wasted step. But if I did a good job with my knife, I should be able to get in there with the cob. And this is probably the step I take the most time with, hands down. It's because I need to make sure that that cob is directly between the end plate and that cartilage that'll come out. If you're in the right plane, the surgery is basically done after your cob. So take your time, get the cob in the right place, and then you go from there. So you're going to denude the end plates, and you get all the way across to the contralateral side. This is just a hiccup I had with a beef I had with the implants that they made for us, that it shouldn't be that wide on the end. We should be able to get all the way across. But they've since revised it. So, but here you release the contralateral side. And then you flip it, go down to the bottom. Notice how minimally open that retractor is, right? You're just trying to minimize the trauma when you're in there. And then you pop that through the other side. The next step is going to your pituitary. So now you've created hopefully a piece of cartilage or disc that wants to come out. Now, that's when I go into pituitary, but I don't pass it through there like 10 times. It's 1, 2, 3, and if it's not out, like I'm on to the next step, because the next steps will also get your disc space prepped pretty easily. So this is not everyone does this. I love it. I use the box cutter on every one of these. It's also the fellow ALL lacerator, right? So the reason I say that is you got to make sure that your cob elevator, that your box cutter is actually inside the space that you created before you start whacking away. Because if that front piece catches the annulus, because it's not deep enough, it'll pull the annulus with you down and it'll just like peel it off. So if I really want to get a lot of lordosis, I have the fellow do this. But if you feel a lot of resistance, like you should double check it. You should not have to pound this thing hard to get it going. It should be inside and should go pretty easy at the beginning. It should get harder as you go through. This is not what I want to see. It's not orthogonal, right? You should be able to see right through the box cutter. It should look like that, right? See the difference? This thing, you should be able to see right through this thing. That way, you know, if your AP image is good, then you should see perfectly straight through the box cutter. Now, if you can do that and you look on the inside and you can see that the box cutter is within the disc, you're golden. You're fine. And then you send that sucker across. And then sometimes you have to clean it at the halfway mark because you got a bunch out. And then you can see what it does to the body, right? Does a nice job of clearing it. Usually take it to the contralateral pedicle. That's a little far from my liking. I don't try to send that across because I think if you send it across, you might shove the disc material that you just cleared to the other side, and then you may not get it out. So I go to the other pedicle, but not past it. And then remove the remaining debris with the pituitary. It's the second time you get to use it. Again, it's not a very efficient tool. And then oftentimes I'll skip that step and I'll go straight to the trialing. The trialing, believe it or not, will clear all that disc space out even more. And at this point, you're like, I don't think I've cleaned enough. I'm like, just trust me, get the sucker in there, because once you take it out and then you look at the end plates, they're clean, they're like punctate bleeding, they look really, really good. The other thing is, like, people that say they can't get a 22 millimeter cage, and I'm usually like, that's probably not true. If you just think about just an area, right? Just an area, right? Which is lifetime width. If you can get an 18 in that's 10 tall, then theoretically it's 180 millimeters squared, right? So if you do the math on a 22.8, it's actually 172. So it's 176. So it's actually less. So theoretically, if you can get an 8 millimeter and a 10 millimeter tall 18 in there, you can definitely get an 822. And once you get an 822, you can almost always get a 10. So there should be very few reasons why you can't get it in there unless you're working through such a narrow window because of like your nerves, in which case you're just trying to get an objection. So the trialing, again, I think is important just from the standpoint of clearing the end plates and then getting your sizing right. This is when you tell your back table what size implant you want, and you can probably tell them pretty quickly. They're almost always 8 or 10s tall. And at that point, you're just like, hey, I want a 45, 50, 55, whatever it is that you want. Sometimes we take it across to get a full release. And here you can see us like lifting this thing way up. That's a 12. A lot of times I'll base this off of what the adjacent levels are doing, what I think it needs, and then the bone quality of the patient. So always check your lateral. You'll see me skip this part based on what I feel where I'm at in space. I would tell you never skip the lateral. Like always take a shot, especially early on. And then and before you go lateral, just tell the back table what you want so they can compare it. That patient actually got an ACR, by the way, if you're wondering why it's gapped open like that. This is post ACR. So then you clean the end plates. There's different tools that we use for that. Stirrup curettes. You can use the raspers, and then you get your two different kinds of ways of getting the implant in. These are like the slides. I like these a lot. I use them most of the time. As a matter of fact, if you're in a really narrow disc space and you can't get your trial in, use the slides. So that's another cool little trick. Just use the slides to get your trial in. So they also make these like graft containment devices that are built into the inserter. So that they work great too. Check your AP and lateral, and then you're typically done. So this is it beginning to end. I think I did an ACR on this one, but just kind of showing you kind of what the steps are. This is every image that we took during the procedure. Here again, we got an anterior retractor, which I don't typically use. Some guys I think still use it, which is fine. But I use an anterior retractor if I'm docked at the 50-yard line or more anterior, then I want to know exactly where anterior. So if I'm able to dock at the 15, 20-yard line, my implant's not big enough to get me that far forward. Here, see we're coming across, and then we already cut the disc. This is the scissor jack to open up the disc space to put the ACR implant in. So bigger than. And these have these little ways of securing the implant to the body, so the student all put a screw in. So that's what it looks like. And then we did one more level. So good. So be consistent, be efficient. Should be simple and elegant. Don't waste steps. Be reproducible. It'll help you. There's your 8 steps. Next questions.
One of the questions I want to know is, do you feel like the future of lateral is still there to stay, or because even within our institution, it seems like there's some transition to PTP. What are benefits or pros and cons of either? Because
yeah, I think there are nuances that you'll see that are different between like PTP versus direct lateral. So I definitely think it's worthwhile learning the different techniques. I think it's you have to do circumspect spine surgeons. I think you'll see some very, very efficient lateral surgery here. And I think when it comes to doing laterals, like being in the lateral position is just easier, better, faster. Like if you just take it as a blanket statement, that's probably going to hold pretty darn true. Now, there are certain instances where, putting a lateral from the prone position may be, a lot of value. So you have a patient that you're trying to do say a spondy reduction on, and they have like overgrown facets, bony, they need a direct decompression, you don't want to flip, et cetera, et cetera. Like I can see where that makes sense because you can kind of get working on both at the same time if you have a team that's able to do that. If you're working on your own, I'm not sure how helpful that is. But you also see here, like for us to go from lateral to prone is like 12 minutes. We flip these patients so darn fast that like this benefit of having it all in one position may not be as ideal, because when you do, even like we do screws from lateral, like it's fine, but that's not easy, right? Like easier is putting screws in from posterior, right? So With lateral, you're sacrificing the ergonomics of putting screws in, which can be tricky. With prone, you're sacrificing the ergonomics of putting the lateral in. In my opinion, the more dangerous operation is the lateral. So if I'm going to veer one way or the other, I'm going to veer to positioning for the lateral because like it's the one I want to make sure I have the most control over. So, but some of that's also experience. Like these guys have done hundreds of prones, like they're going to be super efficient at it. You can learn and grow with it and be fine. Right. The steps, the principles though will be the same.
Yeah.
Consistent, like understand where you're at, know the downsides. Everything drifts anterior when you're prone. So you have to be, you're fighting gravity, because you're trying to be posterior. Everything wants to push you anterior. So there are nuances to making sure that you're okay. So, but that's kind of my take. If you're going to do, if you're in an institution that does not move, I can see where doing it in a single position prone would be nice. Yeah. Hanny, you've done probably more than most in our institution. Any thoughts on PTP?
I mean, I think I just endorse everything you said. And there's a level of familiarity. I mean, probably for somebody like me who hadn't done as much lateral decubitus, the inertia to change was less. Just because I didn't have the expertise and probably the flow that guys like Bob and Greg and Jamie have developed over hundreds and hundreds of cases. But the concepts are all the exact same. And I think that's the important thing. And just whatever's going to be safest in your hands is what you should do. And the nice thing is you'll have some exposure to both.
Are there any high yield tips and tricks of staying out of foul or vascular injury?
We didn't talk single versus dual approach incision. Second incision, that's kind of over the quadratus lumborum. It's definitely a very good tool to stay out of foul. So single incision probably has a little higher propensity to get lost. So if you're questioning at all, then do a second incision. If you're a one incision guy, okay. So I do one incision in general, but if I'm going to a 1-2 or 12-1, I always do a second incision because I want to be below the diaphragm and I want to make sure I'm in the retroperitoneum. And then certainly if someone's had a previous retroperitoneal surgery, they'll always get a second incision.
Got it.
So just
It's pretty interesting, Greg, because I'm I'm dogmatic about that. I know you've gone to single incision, but guys, I'm a 2 incision guy because that's how we were trained originally, to stay out of bad things and use your index finger as essentially an eyeball inside the retroperitoneal
Yeah. Well, if
space.
your index finger is 12 inches long, it can be a really good eyeball.
It's a curse. It is a curse. Yeah. But
The first lateral I ever did was with Bruffy, and he was kind of showing me the ropes. He's like, "Yeah," I was like, "You can go up there and like feel the kidney." I'm like, "Feel the kidney? I can barely get into the retroperitoneum."
You do the left side of the approach, you just fill in the right side of kidney.
Exactly.
Yeah,
That
probably would cause some problems. Yeah, but it's interesting. I jumped into this because I didn't see this in my calendar. But Handy, you talk about the prone lateral, and we didn't really talk. I don't know if you guys talked much about the differences. Are you seeing any differences? First of all, are you using one incision or two?
Two.
I do it the exact. I use 2 incisions. I do it the exact same way.
And I know Bob's a 2 incision guy, and you've done a couple of now prones.
I do both. I do both, but with the prone, as I'm getting into that, I'm doing 2.
Yeah. And your thoughts?
Look, I think the area that I still remain concerned about is positioning.
Yeah.
We for many years migrated to flexing the hips and the knees and lateral decube.
Yep.
And I think that between that and not bending the table or breaking the table, I think that was a major shift for us in terms of complications of that stretch, whether it was retraction stretch or position stretch. Yep. And the prone lateral just starts moving back in the other direction a little bit. So I think my sense is we'll see, for really facile lateral surgeons, an uptick in those issues. And I'm reticent to do it in the more risky situations because of that.
Yeah, that's my gestalt too. you know, I'm a hip flex. I flex the hips up almost, if I can get them to 90 degrees, I'll flex the hips to 90 degrees and then break the table a little bit, not much, just a little bit to get open the crest and the ribs. Because I think I'm placing the lumbar plexus under much less stretch when I got those hip flex, which I know is the case. So extended position prone is, you're right, as it flies in the opposite direction of everything we learned about, you know, psoas muscle relaxation and lumbar plexus mobility in the operative field, especially at L4-5. So that I'm reticent as well. Those are my concerns as well. Thank you, Bob. That's just to pass
I
on
think
from
those are
fellows as well.
valid. I think those are definitely valid. And part of the reason maybe I haven't run into it as much is that my threshold for switching to TLIF or ALIF, I mean, I'm not doing many aggressive laterals with, you know, transitional anatomy or challenging crests or anything like that. So
And
I'm a little bit more conservative.
And Hanny, just let me put past that on to the fellows. Your ability to flip to a TLIF if you have poor access through the psoas because
100%.
of risk factor, that is so key. You guys have to know when to fold them. It's the know when to hold them, know when to fold them thing. And I do the same. If I cannot safely get through the psoas for whatever reason, whether it's not being able to get the bow out of the way, can't feel the psoas well, or the neuromonitoring signals prevent me from safely doing the operation, don't do it. I just had a patient, he's a surgeon actually, came from another city to have a surgery done, and I could not get through the psoas muscle safely, and we had a change in neuromonitoring right after we placed the retractor, didn't even open it, and I bailed. And he was so happy because we did an ALIF and he's done fine. We really, really well, but I could have given him a quad palsy. So you got it. Even now, I know when to abort. So that's so key, you guys.
Yeah, well said, bro.
Yeah.
All right, let's log out of this one and log into the next one.
Thanks.